So a very warm welcome to all of you on this beautiful day here in Madison. I am Jennifer Edgoose, the Vice Chair of Community Health, Diversity, Equity, and Inclusion in our Department of Family Medicine and Community Health. My pronouns are she, her, hers. And just to echo what Shelley said earlier, a really warm welcome to all of you here who are not only wonderful colleagues of mine from within the department and across our clinic system, but many of you are coming from beyond in our greater academic health system, our health system itself, and across the state. So warm welcome, thanks for joining. The title of this forum session is Opportunities to Reimagine Team-Based Care, Partnering with Community Health Workers. And so I'm going to turn this over to Nazca Serrano, who is one of the vital members of our Office of Community Health and serves as one of our health equity coordinators, who's been providing a lot of leadership for the work that we're doing in our department in terms of our deep desire and hope to promote community health workers, not only here in Dane County, but across the state. So we'll turn this over to you, Nazca. Thank you.
Thank you, Jennifer. I hope everybody can hear me okay, but it is so awesome to see all the beautiful faces up here on the screen, and honestly having the space to convene all the expertise and love and effort for and with community health workers. Jennifer just mentioned, I've done a little bit work there, and I still feel like I'm continued learning and growing with community health workers in our community. So I'm really excited to convene all the folks together today. I'll just introduce myself one more time. My name is Nazca Serrano. My pronouns are she, her, hers. And today I have the honor of welcoming into the space beautiful colleagues of ours, and then also our guest, Dr. Kaufman. And first we have Jessica Kimber, and Jessica Kimber is joining us today in a little bit about her background. She started her journey as a community health worker in 2018 at Independent Living Resources in partnership with the Great Rivers Hub in La Crosse, Wisconsin. In her role as a CHW, Jessica worked with a wide range of populations and health topics, including cardiovascular health, diabetes, pregnant mothers with a history of substance use, high ER emergency room utilization, and families with truant children. Jessica recently accepted a position as the Community Health Worker Specialist at the Wisconsin Department of Health Services in the Division of Public Health and the Chronic Disease Prevention Program. And as the Community Health Specialist, Jessica works with the CDC 2109 Community Health Workers for COVID Response and Community Resilience Grant to support grant sub-recipients and CHWs across Wisconsin to strengthen the CHW workforce, promote CHW professional development opportunities, and advocate for increased sustainable funding for CHW positions. We also have the honor to have Marcia Morales, Villavicencio, who is a Wisconsin Community Health Worker Outreach Coordinator with the Mobilizing Action Toward Community Health, otherwise known as MATCH Group of the Population Health Institute. This role is a partnership with the Department of Human Services Chronic Disease Prevention Program to support the sustainability of the statewide community health worker workforce and support statewide CHW initiatives and partnerships. The passion for community health workers emerged from Marcia's personal experience as a promotora de salud with Planned Parenthood of Wisconsin, approving immigrant and lifelong commitment to racial equity and public health. We also have Mary Pasek, who is the Chronic Disease Prevention Unit Supervisor and Program Director of the Chronic Disease Prevention Program within the Bureau of Community Health Promotion for the Wisconsin Division of Public Health, Department of Health Services, and a registered dietitian nutritionist. Mary has been with the Department of Health Services since 1999 and the Chronic Disease Prevention Unit Supervisor since 2013 and is responsible for overall coordination, program and fiscal management of the grant-funded programs, staff supervision, facilitation of several work groups and partner groups, work with internal and external partnerships to identify opportunities for alignment and coordination, and communication with stakeholders. And lastly, with us, we have our guest, Dr. Kaufman, who is the Vice Chancellor for Community Health at the University of New Mexico Health Services Center and is the Distinguished Professor of Family and Community Medicine in the UNM School of Medicine. Kaufman has helped create UNM's Health Extension Rural Officers, otherwise known as the HEROES program, based in the agriculture extension model, which assigns HERO agents throughout the state to serve as community liaisons with the UNM Health Services Center. His strategies have included establishing a family medical residency program that places trainees in under-resourced communities and dispatching extension agents across the state to both identify pressing health, educational, and economic challenges and mobilize resources to them. Additionally, Dr. Kaufman oversees the University of New Mexico Community Health Worker Model, otherwise known as CHW leads, and along with his colleagues have also pursued state and local government funding as well as payer support to hire and train community health workers to engage residents disadvantaged by the system and connect them with medical and social services. Woo! So with all those beautiful and amazing introductions, welcoming Dr. Kaufman with us this morning, this afternoon. Thank you for joining us and being able to share with us all your knowledge and also challenges, no? And so I'd like to start just by asking to tell us a little bit about how you integrated community health workers into the care teams in New Mexico. Some questions to consider: what were the immediate and long-term benefits of this expansion of healthcare, and what barriers did you confront?
Thank you very much. My pronouns are he and him. I'm going to show just quickly 10 slides. I'll zip through them. Okay. So what I wanted to start with was what we learned about community health workers from other countries. We've had community health workers in New Mexico for ages, and there's nothing new about community health workers, but what happened when we saw how community health workers were used in developing countries is they're very much economic drivers. And we thought that we like to import that model as well, where it's a health service, but it's also developing economic resources for their communities. This was something we had done to start out, which was just having our community health workers that are always in the communities, but not in the health system, tell us what are the most common adverse social determinants. And so we put together this prescription pad, but we asked over 50,000 patients that came to primary care clinics at the university and our federally qualified health center. And what they told us was astounding. Over half of them had at least one adverse social determinant. Half of those had more than one. Even more had, yet more had 5 or 6. But this was unknown to the healthcare system because we don't ask these questions. And it was very important for us then to say, with this data, could we then employ community health workers in our system so we could ethically ask the questions and intervene? So the hospital agreed, and they put a community health worker in every single primary care clinic, and in the 7 or 9 clinics at our partner federally qualified health center, at least one community health worker there. So we had a very robust number of community health workers in the healthcare system. That was what was innovative for us. This is what it looks like when I go to clinic. And Dave Rakel and I share Gwen Blue Eyes over my right shoulder. She's actually a spectacular community health worker. She's Pueblo Indian. Above my head is my medical assistant. That's the team. I'm totally dependent on that team. And if that team is working, we zip through the day. If someone is sick or out, I'm stuck. I'm way over. I'm staying too long in the clinic. But this provides the entry, that is the community, the medical assistant asks all the social determinant questions, and any that are positive go to Gwen over my right shoulder. This is quite a team. Well, we got a lot of data from our use with community health workers. Our data show that there's about a 4-to-1 return on investment for the money that goes into hiring community health workers. It's a huge saving in decreased hospitalizations, decreased ER visits, decreased cost of medications. State Medicaid in New Mexico, we're an expansion state, then looked at this data and they agreed that every managed care organization that they fund has to put their dollars into hiring community health workers, whether they hire them on their MCO or they pay clinics and hospitals to hire them. That money has to go out to the community health workers. The community health workers are absolutely the masters of social determinants, and they are very well trusted by their communities, much more than the university or the hospital is. And so we have them teaching students and residents social determinants. They're part of our faculty now. This is now a program that is spread around the state. We did a study, it was a modeling study of what is the impact of adding a community health worker to a patient-centered medical home. And the patient-centered medical home is kind of re-envisioning primary care, where it's much more using every provider to the maximum, of to the height of their abilities. But while it saves or it improves health, it doesn't do much to decrease cost. But when you put a community health worker in that can deal with all the social determinants, you then have major cost savings. And this is an example of one of our favorite community health workers. She runs a clinic for undocumented immigrants, and it's a favorite clinic of students and residents who work in a part of the community that's very high migrant area. And she concocted a salidas, an exit interview. So no patient leaves that clinic unless she or the other community health workers reviews what we said. And we find half the time they come back and say they didn't understand what you said. They can't afford what you ordered. The place you sent them has no translator, on and on. So they really do run the show. And then the spinoffs. Now, as it turns out, we've got major grants because we have this ability to have community health workers, not just in the community where they traditionally are, but also in the middle of the healthcare system. And so we do intense case management. They are the masters of finding and helping clients get earned income tax credit. That's really hundreds of thousands of dollars going out into the pockets of indigent families. They also have a large rental assistance program. We set up health services in hotels for the unhoused and COVID positive. And then we have other contracts and grants for housing for returning citizens out of jail. Now, this is what I was asked to talk about also. There are major barriers when we started, not now, but when we began. Who are these people? They don't have certification. There's no, license on the wall of their office. Isn't there a liability to having people like this who are so, quote, untrained, taking care of our patients? And the other thing is, maybe this is from the community health workers themselves. Maybe this is not such a good idea. Aren't these large health systems just using us as cheap labor and distorting the role we have with our communities, where we lose trust because we're working for a system that's not that well liked all over the state? So, and then the final is, if you really valued us, we could bill for services just like you do. And what's interesting is Medicaid resisted this for years because they felt anything that people would bill for would run up the cost of services. Now, under the new waiver they're applying for, they're going to have community health workers actually bill for their services. So this is a huge development. Thank you.
Thank you so much, Dr. Kaufman. That was so useful and so enlightening too to hear. I think like just language or answers to some of even the questions that are generating here in the state of Wisconsin and definitely in community spaces. So it's so nice to have, I think, someone who has been doing this work tell us a little bit more about the model in ways that it is integrated in how it's working too and things coming up. So next also, right, like I think it's really important to also open up the space to hear directly from the folks who we're working with and community health workers themselves and share their experiences. And it's really an honor today to have Jessica Kimber, Marcia Morales, and Mary Pesek also give us a little bit of the overview, right, of just the climate of the community health in Wisconsin, and just giving the room to Jessica and Marcia to tell us, yeah, a little bit of what's it like in Wisconsin right now with community and for community health workers. What challenges do our CHWs expressing, and what can providers do to help support the CHW workforce, and what is being done right now at the moment that you all can share out?
Well, I'm Jessica Kimber, and I'm the CHW. First, I want to say that like I'm really grateful or happy or excited to be invited into this space. I've noticed more and more spaces are bringing in seasoned CHWs to hear their perspective. So thank you for having me here. So I'm just going to start off with a quick definition of the APHA definition of a CHW and like some basic core roles. So the definition is a community health worker is a frontline public health worker who is a trusted member of or has an unusually close understanding of the community served. This trusting relationship enables the worker to serve as a liaison, link, intermediary between health and social services and the community to facilitate access to services and improve the quality and cultural competence of service delivery. So some of the core roles are cultural mediation among individuals, communities, and health and social service systems, providing culturally appropriate health education and information, care coordination, case management, and system navigation, providing coaching and social support, advocating for individuals and communities, building individual and community capacity, providing direct service, implementing individual and community assessments, conducting outreach, and participating in evaluation and research. So how does that definition and those roles play out in like a real life connection with medical providers? There's always seemed to have been some trust issues between some communities and the medical community. I believe during COVID, we all saw how deep that mistrust can go between medical professional or between mistrust and incredible amounts of misinformation being spread through social media and the news and all sorts of things getting intertwined like religion and politics. It was really hard for experts and medical professionals to get the message out there to the communities. This is where CHW core roles really played out and CHW stepped up. CHWs are part of the community they're serving and have worked to build trust with the members of the community pre-pandemic. A lot of us anyway. I was CHW pre-pandemic and had that relationship built. Community members trusted CHWs during COVID with ever-changing guidelines and vaccine information. I had a full active caseload in my community during COVID. I had trusted relationships with everyone on my caseload before the pandemic hit. I met with community members to walk through misinformation from conspiracy theories to just listening when they had medical trauma, like from the past that was making them hesitant, to safe cleaning tips. I was on the phone with a gentleman who was like, I'm cleaning really well and I have bleach and ammonia and I'm scrubbing, and I go, no, you need to get out of there. And then we developed cleaning education to make sure that people were safely cleaning to give to community members. And also like basics of like the science behind masking, why it works and how it works. I worked with one person who was absolutely adamant he would not get the vaccine. His pastor and community had given him multiple reasons why he should not. I spent a good part of meeting with him just listening to him and his community's like trauma with vaccines and medical professionals and like some religious reasons why. And then I said, you know, I hear everything you're saying, and I presented my information to him. I'm like, can I share this with you? This is from the experts. These are all facts. This isn't my opinion. I just want to make sure that you have all the information to make the best medical choices for yourself. It turned out that later on he did get the vaccine, I found out, and I left him with that education. So my hope is that he shared it with his other community members, and building that trust, spread that information in a trusting way between community members, but also in an accurate way, that they were actual facts from experts. CHWs are a huge bridge between community members and health systems and resources and social service systems. Since I'm a CHW and I've lived experience, how I make connections with people is sharing stories. So I'm just going to share like a success story of one community member who he was experiencing homelessness and he was struggling with alcoholism. And when I first started meeting with him, it was just in parks, and I would bring like socks and food and water and things like that. And he actually told me later on I was kind of annoying, but I grew on him. He ended up getting hurt and having to go into the nursing home. But the work we did while he was in the nursing home led to him moving from there into his own apartment. And during that time, we made connections with other community organizations for his like addiction or substance use and his mental health. He reconnected with his primary doctor. When we got him back to his new apartment, we got on the phone with a pre-pharmacy student from the pharmacy who went through all of his medications and answered all his questions on his diabetes, and it finally was regulated after 5 years. So now that I've given you a little bit of a perspective of what it looks like for all of those connections to be made with the CHW, I'm going to pass it over to Marcia, who's going to give like a bigger picture of what it looks like throughout Wisconsin.
Thank you so much, Jessica. I always love hearing about your work. And hello, everyone. My name is Marcia, pronouns she, her, hers. And yeah, I'll just like to guide us through some of what CHW work looks like in Wisconsin, right? So you have all heard about the definition of community health workers. And in Wisconsin, CHW work has existed for a really long time, right? And grassroots community organizations have truly been the backbone of this movement. And some organizations are actually here with us on the call, which is really exciting. And as you have heard, right, community health workers are public health frontline workers and the bridge between the community to health and social services, and very uniquely positioned in the field because they address the root causes and social determinants and so on. They can work in Wisconsin in, as part of a health system, as part of a community clinic, a nonprofit organization, or really in the community itself. CHW, the term CHW can be an umbrella term for roles that address the root causes and social determinants. So sometimes we'll hear promotoras de salud as a title, Also, community health representatives in our tribal communities, doulas, right, really focused on the maternal child health. But at the core, a lot of these roles share a common thread, which can be lived experience and being a trusted member of that community. So one thing also that you'll hear a little bit from Mary today is about the efforts to support community health worker sustainability. And the question is always, how are community health workers getting paid, right? So this workforce has traditionally survived on grants, and Wisconsin currently does not have a standardized way to reimburse for community health services, for community health worker services like other states. So referring to Medicaid reimbursement as an example. And this is such a huge focal point of advocacy that Mary can share with you all a little bit later. But how CHWs get paid really varies depending on what type of infrastructure is set up to support their positions in an organization. So it can be dependent on grants, perhaps have fully funded positions as part of an operating budget, work limited hours, or volunteer, and sometimes not get compensated, which is unfair and definitely not ideal. So working towards sustainability. And I wanted to share with you all just three organizations that do a really great job in this state. And these are not obviously the end all be all, but just three examples of how CHW, of what CHW work looks like across Wisconsin. So the first one is North Lakes Community Clinic. And this is a clinic in northern Wisconsin. Well, they have 6 clinics, but they're located in the northern part of the state, in Turtle Lake, Ashland, White Lake, etc. And they have community health workers working in that clinic. And their CHWs receive training. They're working with the EMR system through Epic. They track social determinants of health. And they make it a point to collaborate across I see Dr. Lee, you're shaking your hands. But they make sure to collaborate right across departments. So lots of partnerships between behavioral health. So it's really cool what they're doing, and they have such a really great team. And they have community health workers that get referrals from providers and have, like I said, a strong program with great support from their supervisor. Then the next one that I'd just love to call out is our tribal nations all have community health representatives. The CHR program was funded in 1968 and is funded through IHS, the Indian Health Services. And CHRs all across Wisconsin are working with a high need population, elders in the reservation, and typically employed at the clinic. They provide medication delivery and really focus on that cultural piece and providing cultural information that makes sense and is able to meet the needs of the community. Then next up, doula groups across the state, one being the Harambe Village Doulas, a community-based organization in Madison. They have trained doulas that provide doula services and education to BIPOC families in Madison at no cost. And they support community capacity through empowering families and therefore improving birthing disparities. So as we can see, the CHW work is not a one size fits all, but the common thread is that community health workers care deeply about the people that they serve. And despite some challenges, they're really able to be that backbone of their communities. And currently, there is a lot of momentum and support for the workforce, both statewide and nationally, due to the silver lining that COVID provided. And thinking about leaning into this opportunity to help sustain the work. And I'm not going to get into it, but you all know that COVID already highlighted all the disparities and all the inequities that existed in our communities. And CHWs have been uniquely positioned and are trusted messengers and able to reach those priority populations. And they've been doing this work for such a long time and have a key role in the COVID response and recovery efforts within our public health infrastructure to help communities build capacity, recover, and heal. So like I said, so much momentum, so much more excitement to support the growth and the infrastructure of the sustainability of the CHW workforce. So it's a really exciting time, both nationally and also statewide, local too. So next, and I will make it quick because I'm keeping an eye on the time, but as we think about opportunities to support the CHW workforce, I'd just like to guide us through what thinking beyond the clinic walls can look like in some ways that you as a provider can support the CHW workforce. Also acknowledging that you all have a lot of responsibility on your plate, limited capacity, limited time. So this can definitely be a continued conversation where we can identify some good places to start. So the first one would just be to value community health worker wisdom, to value their expertise and their lived experience as we do degrees. CHWs are the experts in this work, and they know their communities the best. So this can look like listening to understand, right? Especially when it comes to cultural traditions, ancestral practices, different practices that can be such an amazing asset to the patient, to the client that you are working with. And also it can look like referring to the nothing about us without us principle of the community health worker movement when working and engaging with community health workers. And it can look like doing with, not for, community health workers and supporting already existing work in our communities and supporting what's working really well rather than reinventing the wheel and engaging CHWs from the start. The second point is how just placing an importance on how building relationships is key and acknowledging again that you all don't have a ton of time, but it can be a good place to start to identify what your clinic is doing to support CHW work, and the Department of Family Medicine and Office of Community Health is a really great example of this. So learning about what initiatives they're supporting that you can connect to in your work. Also attending community events, a local convening, visiting CHW organizations, etc. And the third one, and then I'll pass it on to my colleague Mary, is to become an ally of the CHW workforce. It can look like continue to spread awareness of the role and also the importance of community health worker workforce and team-based care. And also as part of the public health response. Also, if you're working with CHWs, refer to and utilize those best practices and national resources. A good place can be the National Association of Community Health Workers, NACHWA, to continue educating your staff about CHWs, ensure correct support and resources for your team, and also champion advocacy efforts and thinking about what advocacy with looks like versus advocacy for. Again, this can look like having trusted relationships with community health worker-led organizations, asking them what they need and what will be the most helpful in their work. One example is utilizing Dr. Day to advocate for sustainability of the CHW workforce. And again, shout out to the Department of Family Medicine, Office of Community Health for being such a great CHW champion and taking initiative to really support the strengthening of the workforce. And again, this opportunity can be a continued conversation and some ideas to kind of to marinate and ways that you can engage and support CHWs. So yeah, thank you for your time, and I will pass it to Mary, who will tell us a little bit about what the state of Wisconsin is doing to support this important workforce.
Perfect. Thank you, Jessica and Marcia. Just really appreciate everything that you said and do, and really also want to recognize the other CHWs that have joined and CHW allies that are on the call. This certainly is, kind of takes a village, right, to do this work. And so at, DHS, over the past probably 10 or so years, we've had very topic-specific grants that have been able to incorporate CHWs as part of the workforce or the approach, whether it be our chronic disease prevention grants, asthma, HIV, a variety of other very topic-specific. And we've operated very much probably in silos over those couple of years. More recently, I think, again, the silver lining that COVID brought us also brought some additional funding. So it was mentioned earlier, we have received 2 3-year grants from CDC that started a year ago, August, really to lift up the community health worker infrastructure and support for COVID response in resilient communities. And so we're involved in that effort in Wisconsin, but we also have been able to stand up a national training and technical assistance center who is providing that TA to 67, 68 other grantees across the country, including the islands. So we've been able to accumulate a lot of expertise in our work in community health workers. So you know, I think just kind of laying some of that groundwork has really brought us to this point where there is so much momentum and interest and really like right time to you know, highlight where community health workers are a natural and critical part of the care team, which has been, you know, done here in the chat as the conversation has gone on. So I think at DHS we've recently convened an internal work group. Like I said, we have all these silos of activity. So how do we start to break those silos down and really have a comprehensive strategy around community health worker as part of the public health workforce, as part of the healthcare care team, looking at financial sustainability. You know, obviously Medicaid is within the Department of Health Services, and I thought I saw Dr. Huebner on here. So really conversations about, you know, how does Medicaid coverage work? Do we need other policy changes to make that happen? Do we have the authority to make some of these changes already? That brings up conversations about core competencies in training, and how do we know what are those training programs that exist, like Milwaukee AHEC, that be enough documentation for community health workers who might seek reimbursement. So as Dr. Kaufman said, that was one of the barriers. So I think we're working through those details, but also then I think part of this comprehensive package is looking at supervisor training as well. You know, so you can't hire CHWs and not also make sure that you're providing appropriate training for the supervisors, because it is a little different. CHWs have the lived experience. They're coming from communities. They're working in a very close, tight relationship, you know, so we need to make sure that they have the support, the self-care, the resources to do those things, and the permission to do those things in some cases. So really looking at supervisor support. Also, you know, communication, so people understand the roles of community health workers and what's unique about a community health worker versus, you know, other patient navigators, other like titled positions that might have uniquely different roles. So how to kind of tease that out. So that's also part of it. Documentation is another piece of the puzzle. So how do the referrals flow back and forth between the organization, whether it be the health system or a community-based organization, to the community health worker and then back to the referring agency? Where is the information getting documented? Do community health workers have access to the electronic health record? What about in community? So I think, you know, really teasing how do we document, because if we're wanting things to be reimbursed and paid for, we need to make sure that there's an appropriate system for documentation. How do we do some of the evaluation? I think Dr. Kaufman brought up some of the numbers, and you know, how do we show that there is a cost effectiveness, that we are meeting the needs of the clients and the patients that we're seeing, that you know, that we're getting better control of hypertension and diabetes, and you know, some of the other the vaccination rates obviously have been important the last you know, couple of years. So how do we build in the evaluation of this? And then I think really just, building the workforce. So how do we make sure that we have position descriptions, within a state government agency like we are here within the university system? There isn't a classification or a position for community health workers right now. So how do we kind of change that with the appropriate pay? So, academic institutions often like credentials, I'm a registered dietitian, there's training that goes behind that. So how do you, bring in to the workforce with those appropriate classifications? And then just generally the partnerships and the awareness, the communication around what is a community health worker, where do they fit within the care team? So really looking at, again, not just financial sustainability or not just this, but really how do we, have a comprehensive strategy across DHS, across, some of the other partners that we work with. So we are making, some progress, but that there's obviously a lot to do with that. But it feels really good. This couldn't have happened 10 years ago. I don't think this could have even been a conversation that we might have had even 5 or 6 years ago. But again, right time, right place, and, kind of being able to move forward with that. So I think I will turn it back to Nazca so we have a good amount of time for questions. I see a few things in the chat. So back to Nazca.
Yeah, thank you. Wow, I'm like just in sitting with just so much, hearing just all of the different perspectives here that we have today, all of the different wisdoms and all the different stories that I got to hear from people, and also just alone in this room, like having so many people from different levels of this work convene together is feeling truly like this is also part of the work that we are talking about developing. So I just wanted to thank each and every single one of you for sharing your knowledge, your labor, and your commitment to this work on all levels. I appreciate you all sharing the history of CHW work and reminding us that this work is not new. It has history, it has love, it has complexities, and it has community collaborative power, and that it works. And one thought that I'm leaving with is, how do we continue being responsible in the work to integrate all these efforts? And how do we braid these stories in ways that truly honor frontline workers, where we're not just placing chairs in our tables, but we are actually asking permission to share space in their tables, where there's resources, where there's also love and history? And how can we be more creative about developing this workforce in a time where there's such a powerful momentum? So thank you all for sharing the space today. Thank you to all the guests, the presenters, and the people who have convened and made this possible. We do have some time left for questions that I would love to to just open the space up for, and continue to braid ideas and braid efforts in this way. So thank you all for, and also allowing me to kind of be the moderator for this conversation. It's truly exciting, so I appreciate it. And you're more than welcome for folks. We're just opening up the space for any questions or any also thoughts. Welcome to use the chat or also go off mute.
Dr. Kaufman, at the beginning of your presentation, you shared like a quick slide of your prescription sheet, and that's what you would then say, or would your MA doing their referral and doing the assessment saying, check, these are some of the things, and now I'm handing them off. You're going to now meet with my community health worker. How did that work?
Right, good question. So the MAs are the ones that do the screening. And that's why the MA has to be within the health system. They have to be a part. Our clinics are filled with MAs, and they are the new kind of workforce. And we are actually trying to create a career ladder for MAs to become community health workers because their pay is very low. Their certification is very expensive. But the community health worker is something many of them aspire to. So they do the screening. Then those that are positive can be referred over into clinic to the community health worker.
And does the community health worker also have access to the EHR?
Yes, all of them, and they can have notes. Actually, some of my best stories are, I just copied them from the notes they sent me about the patients I referred in. So that's also, and I think that was just described. Very important that you have access to the electronic health record. What we're also trying to do is where you have the vital signs, we're trying to make sure, if it's possible, to have the adverse social determinants like a flashing light right by the vital sign so everyone sees it.
Thank you.
In the chat, we also have a question from Sonia. Sorry if I'm mispronouncing the name. But it says, would we be able to see more data on the cost savings that was mentioned by Dr. Kaufman?
I gave some of the articles we've written to the team here, and I'll send a few more. And it has the breakout of what that cost saving is. It's enormous. It's really high, to the degree that state Medicaid now requires, because they're going to save a lot of money in this. So I'll make sure that your team has that.
Okay, I have one last question. I hate to try and pack it all into the dominate. Okay, Shelley said, give him the green light. Okay, Dr. Kaufman, here's another thing, and for the entire group. Hate to be the Debbie Downer, but I'm always trying to have like this backup plan. Like, what happens if things change drastically in our Congress, and that folks do decide that they want to take away certain things within Medicaid, Medicare? How will that impact reimbursement for CHWs? Whereas Wisconsin, we haven't even gotten to that point. And that's one of the things we're most looking forward to. What is the backup plan if Congress changes?
Me. Telemarketer. That's an easy question. I'm sure others can answer it. One thing I would say is that when you're talking about saving dollars, reds and blues tend to like that. Now, how you frame it is important. For some people, you're going to save dollars and you're going to increase personal responsibility. What? Okay. For others, we're going to change structural. Okay. So I think that requires a discussion of how you frame things to make sure it fits into people's framework and their backgrounds and whether they're red or blue. It's sad that it has come to this, but I think that's your best option.
We also have another question in the chat, and it says, Dane County Senior Centers are collecting a lot of social determinants of health and information. Is there any way that this information can be shared with medical providers? Hospital ER, RNs are needing to collect this information as part of their intake.
So I can maybe start and others on our team can jump in. So I think with our One COVID Response Grant, we're working really closely with the Greater Wisconsin Agency on Aging Resources, GWAR, and they work with the ADRCs in throughout the state. And so we actually are providing some funding to what we're calling 5 different catchment areas, kind of CDC terms. So Dane County is one of those areas. Wood County, La Crosse kind of area, Sheboygan, and then southwestern Wisconsin. And so GWAR has been working with ADRCs in a few of those areas to hire the CHWs. And again, nothing's as easy as it sounds on the front end. So I think there were some challenges with the ADRCs, one not being at, capacity being one, but also I think they were worried about sort of the referral pathways in terms of if the CHW is hired and working at the ADRC, that may endanger some of their other federal funding. So I think we're still kind of working out the nuances of that. And so we've been able to put, have CHWs working as care transition intervention coaches in like a YMCA and doing some of the referrals that way back to the ADRCs and Inclusa, which is the family care program. So I think there's a few like pilots underway with our funding to involve the CHWs and the ADRCs. There's also another health equity grant that our Bureau of Aging and Disability Resources has also provided some funding for, 3 or 4 ADRCs to hire the CHWs. So I think it's emerging. We're still trying to figure out the details of that, but yes, very good idea.
Yeah, and I would also like to add, thank you, Mary, for sharing your thoughts. But I think that there's a lot of power in sharing and disseminating and dissemination of this work, especially the results. We all know that the CHW intervention works. And there's a lot of data, but to keep sharing, right? And I think about one of those spaces being the Wisconsin Public Health Association. I see some folks who are part of the association are here as well. They have convenings. Also thinking about the Wisconsin hospital associations. They have different meetings. So to keep spreading awareness and advocacy about the CHW workforce and that as an intervention, right? The way, yeah. So I would just like to add that. And I think I see Brenda's question: what education are you requiring for community health workers? I don't know if that was for Dr. Kaufman, but I think I can weigh in that for some of the grants that we're involved in as part of 2109 and other organizations that I've seen, I believe that they required a high school education, but others please weigh in. And I think that that's also an initiative to lessen the barriers of application, because the lived experience is so rich that I've seen that, but others please weigh in.
In New Mexico, there's a certification that's given by the Department of Health for free. Community colleges usually will charge something for it, but for the community college to have an alternative, it has to be approved by the Department of Health that the same basic structure is satisfied. But this was a conflict in the beginning because many community health workers were doing this for 20, 30 years. Now you're saying that I'm not worthy and I have to have a certification. So they grandfathered in large numbers of community health workers right in the beginning. And now it's required to get, and it's not required to work, but it's now you have to get the certification without being grandfathered in. And the concern, I'm not concerned, but there is a concern that will be required for employment in the future.
Yeah, that's such great information, and thank you to the folks who are also sharing their thoughts and their ideas here on the chat today. And truly, right, making those links and braiding this wisdom. We have about 4 minutes, and I just wanted to open up the room again in case there's other folks who have questions or any also thoughts or ideas that you want to share out with with everyone. I know I'm learning so much just being here with y'all today. So opening the room or the space one last time for any questions before we head out.
Hello, everyone. This is Elise Ward. I want to thank our guest speaker and all of the other folks who shared. This is just very, very helpful and important work. So glad to hear of the contributions that you all are making. Thank you. Grateful. Quick question to Marcia, and it looks like she responded in the chat. I was asking her about the work that is being done to the North Lakes medical clinics out there that at the Cancer Center, we are doing prevention work out there, given high rates of cancer in rural communities, and wanted to see if we can connect with the community health workers out in that area. So, Marcia, I look forward to connecting with you. Thank you.
Thank you. And I just want to say I spelled your name wrong, Erlise. I'm so sorry. And I look forward to connecting with you. I just will drop my email in the chat.
Awesome. Thank you. No worries about my name.
Thank you, y'all. And then I see also Leslie McAllister with a question.
Sure. Can you hear me all? Everyone? Okay. Sometimes Webex does not like my computer. But I guess one of the questions or one of the things that I've not really heard discussed is, while there is definitely ample support for having sort of one-on-one intervention with community health workers, we are operating from like a sort of community-based environment, and we see that there's a ton of opportunity around sort of group health education or group experiences that promote community wellness as well as individual wellness. And I'd be curious, from your perspective, Dr. Kaufman, like, how is that working, and how does that get paid for or supported by the systems, the healthcare systems in New Mexico?
It's absolutely the critical question, because investors and private insurance companies want a quick turnaround, and community health workers can actually do that within months. But when you get into the policy changes and the structural changes, that takes months, or it takes years. But it's probably more important in the health of society. Community health workers can be part of that and are part of it. The health extension are almost full-time trying to do that, and therefore they're harder to fund. But the community health workers, I just wanted to mention this point, are doing something very valuable. And that's why family medicine within the house of medicine is so important, because they kind of take care of everything. But when you look at the medical system, it's very fragmented. And that's why CHWs may get a grant to do hypertension, to do diabetes. Well, what about COPD? Have you thought about smoking? I mean, each one of those are totally fragmented. But when the community health workers intervene upstream, and they are dealing with social determinants, they affect every single one of those categories. So in a way, it's much more efficient. And that, I think, is a message which we have to send. To get back to the comment, I believe that the navigation doesn't only have to be with individuals. That can also be with community, just as you had just mentioned. And I think that's the next big step, because it's longer, but if we could tie them together, then the community health worker doesn't only have to be put in the box, you'll only deal with individuals. They can get a quick turnaround that's valuable for individuals. They also could be working at the policy level, which is so needed.
Thank you so much for that last takeaway. Thank you for that message, Dr. Kaufman. Thank you all for attending this space and for convening together. It was an honor to just host these conversations, and I hope that this is just a little branch, right, of the possibilities, and that these spaces continue to happen. I don't know if Jennifer, anyone from the department would like to close up, but otherwise, thank you so much for your time.
Thanks everyone for joining us. Appreciate it. Have a wonderful day.
Thanks so much.
Thank you, everyone.